As a woman, we often think of our menstrual cycle as a 5 to 7 days of a month where you get your period or menses. But actually, this cycle includes the weeks leading up to your menses as well. Today on Lunchtime Live at the Center, we're talking with Dr. Andrea DiLuigi, a lead physician here, about the phases of your cycle that lead to the week of your menses, which hormones are involved, as well as how this mirrors your fertility treatments. Hi, Dr. D. How are you?
Hi, Ami. Thanks so much for hosting this.
Well, welcome back. Dr. D, can you talk about what happens during your menstrual cycle?
That's a loaded question, Ami, but I will say to start that there's a lot going on behind the scenes. And a lot of times patients are pretty surprised when they read about all the events that have to occur in synchrony to have a pregnancy happen. So let's try to break it down so that it's a little easier to understand. And hopefully we'll be able to post some kind of a chart on our website at the end so that people can have all these hormones written down. But you can basically artificially kind of divide the menstrual cycle up, but it's a continuum. Obviously, things are happening every day behind the scenes. But if we think of it in two different phases, we would divide it into what we call the follicular phase, and the second phase would be the luteal phase. If you do some reading online or in medical books, sometimes people will divide it up into 4 phases where they count menstruation or the period as one phase, then the follicular phase, then ovulation as its own phase, and then the luteal phase.
Okay. So for each of those phases, so can we, which one do you typically start at, follicular or menstruation?
So I like to just explain to the patients that starting the clock because it's useful for thinking that way when we compare it to, for example, like our IUI cycles or our IVF cycles, that cycle day 1 is typically numbered as the first day of your period would be cycle day 1, so first day of full flow. So I like to think of it starting there. So at that time of your cycle, all of the hormones are low, so they're normal. So if you were to check labs on somebody on the first day of their period or the second day or even the third day, you would expect to see that everything is pretty quiet behind the scenes. So a low FSH, a low estrogen, a low LH, and a low progesterone, and a negative pregnancy test if someone is not pregnant, obviously. So then what happens from there, once the brain realizes that the body is not pregnant, it starts over to start a new cycle. And it's pretty complicated what happens behind the scenes, but the brain, once it realizes that the hormone levels are low, it sends a signal called FSH, or follicle stimulating hormone. So the brain makes this in the pituitary gland, and it sends that signal to the ovary. And then when the ovary responds, it starts to have a fluid-filled sac called the follicle with the egg inside start to develop. And at that point of the cycle, the lining of the uterus is shedding, so it's typically thin, or it's getting thin. So again, everything is quiet, the hormones are low, and then things are starting up again. So that FSH would be the first signal. And then as the follicle starts developing, it starts to make estrogen, and estrogen makes the lining of the uterus get thick again, and it rises as we get closer to ovulation. So I'll stop there for a second, Ami, and see if you want to ask any questions.
So the key hormones in the follicular phase or the menstruating phase is FSH and estrogen, right?
Correct, because at the beginning of that phase, everything is low. And that's what brings the period on. Actually, the fall in progesterone when someone is not pregnant makes the lining of the uterus shed, and the whole cycle starts over. So yeah, the key players in that phase would be the FSH and the estrogen from the developing follicle.
And does estrogen continue to rise, till you ovulate?
Yes, so the follicle, as it grows and develops, it makes estrogen. The estrogen makes the lining of the uterus get thick again. And then once the estrogen gets high enough, the brain gets that signal. And once it reaches that critical threshold, the body makes another hormone called LH, or luteinizing hormone. And that is the surge. And that is what makes the follicle release the egg. And that's ovulation.
Okay. And ovulation, so the LH surges right before ovulation or during ovulation?
Yes, so right before, so we can track that either with ovulation predictor kits or with blood work, and it starts to creep up and then it spikes and then ovulation happens. And then the ovary makes progesterone after we ovulate. Think of, if you had to draw this on paper, since we can't show you a chart with this format, think of like a typical 28-day cycle divided in half. So the first half of that is the time that it takes to make the follicle and have that egg start to develop inside and thicken the lining of the uterus. And then, right in the middle of that graph would be the spike in LH and then ovulation. And then we're in the luteal phase. So the luteal phase is the second half of the cycle. It's typically about a 2-week phase. And our ovary is then making estrogen and progesterone, hoping to be supporting a developing pregnancy at that time.
Okay. So your menstrual cycle is actually in the follicular phase, not the...
Yeah, I mean, if you number it there, yeah, so some people, again, will, if they draw this out, will say like the menstrual phase can be up to the first 7 days, and then you have the follicular phase, but you have some overlap because the brain starts to make the signal. I mean, before someone's done bleeding, we're preparing for the future, in other words. So they're not really like distinct phases where one event happens, ends, and then the next happens. It's and think of the follicles as, they're always there in our ovaries. So we have like a little pipeline going on. So we have things are happening every day in the body. And then in the menstrual cycle, one of those follicles gets chosen to be the lucky one or the selected one to grow, develop, and ovulate. And the rest that we have visible on ultrasound that month will get reabsorbed.
So if we move towards fertility treatments, how do these phases work, say with IUI? How does your cycle mirror what you're going through with IUI?
So I want to comment on one thing just so this will make sense for the next question, and then I'll definitely answer that. I just want to say that when we ovulate, the follicle becomes a cyst, but it's a functional cyst and it's supposed to be there. It's called the corpus luteum, and it makes estrogen and progesterone to support a developing pregnancy. So if someone does not have implantation and they don't get pregnant, those levels fall because the lifespan of that unit is limited. It's like 2 weeks. So the estrogen and progesterone levels will fall. The lining of the uterus would start to become unstable and shed, and then the period would start and the whole thing would start over. If there's implantation, the body is very smart and it gets the signal from the pregnancy hormone, the beta HCG, and that hormone will tell the ovary to keep making the hormones. So if someone gets pregnant, the estrogen and progesterone levels don't fall, they'll stay elevated, and that corpus luteum cyst will keep making the hormones until the placenta becomes fully functional. So to take that into our cycles, it'll help make a little bit of sense there because, for example, we use progesterone in some of our cycles, and I want to explain that. So IUI is, it's very similar to what I just described. So someone would have a period, and some of our patients, when they're doing IUI cycles, are taking medications, and some are not. So let's just use the natural cycle as an example. So a natural cycle IUI, what those patients typically do would be to test with an ovulation predictor kit, and some of our patients are having blood work. But whether it's an ovulation predictor kit or blood work, the goal is to pick up that LH surge so that we can time the insemination appropriately. So the beginning part of the cycle would be the same. There's a period, there's a follicle developing. We're picking up that LH surge so that we can time the insemination so that the egg and sperm will meet at the right time. So someone is ovulating. The day they're ovulating is when the sperm would be placed into the uterus. And then their body would be making those hormones. So they'd be still making the estrogen and progesterone, and hopefully there'd be implantation, and then the period wouldn't come. So the progesterone maintains the lining of the uterus and it prevents it from shedding. So if someone is pregnant, they should not get a period, that should maintain the level. The other thing that can maintain that level is progesterone supplementation. So I want to talk a little bit about that. So For some of our cycles, we're using progesterone supplementation, and there are different reasons why that may be recommended. For example, I mean, we can jump to in vitro fertilization and say that when we do IVF, it's very similar. You have a menstrual cycle, a follicular phase where you're developing follicles, but the goal is to have multiple follicles with eggs develop, because we want there to be a higher yield than just the one that someone would produce with no medicine. So those patients are taking injectable medicine that contains FSH.
Okay.
And then we do the egg retrieval instead of having someone ovulate, and then fertilization happens, and the patients then start progesterone. And the reason why the patients that do IVF, that are having an embryo transfer, I should say, start progesterone is because when we ovulate in a natural cycle, there's nothing that is disrupting the cells that make the progesterone. When we do IVF, to get the eggs, we have to do an egg retrieval. And a needle goes through the wall of the vagina into the ovary, and there's a very gentle aspiration device that aspirates or suctions the fluid out of the follicle, and with it comes the egg. But sometimes some of the cells that make progesterone can be aspirated too. So it's important to give the patient progesterone back.
Okay. Now, so if progesterone is produced in this luteal phase, is there, I don't know if this is even a diagnosis anymore, of a luteal phase defect. Is that related to progesterone typically?
Yes. So if you do some reading online, you'll see that this is a controversial topic, but we know from even taking a history on a patient sometimes that some patients don't have that standard luteal phase length of about 2 weeks. We'll have patients that will have a very short luteal phase. For example, in talking to patients, a patient might tell us that, okay, it takes me 14 days to ovulate, and I get my positive on the kit, but my next period comes like a week later. So that tells us that luteal right length, that it's not enough time to give adequate support for implantation in a developing pregnancy.
Okay. Now, when we in IVF, what is the role of say like Lupron? Lupron, what does that do to support an IVF cycle?
So great question. So there are different ways to utilize Lupron, but one of the most common ways is to prevent ovulation. So in an IVF cycle, you need something to stimulate the follicles to develop. So that's the injectable FSH, and sometimes we're using another medicine that has LH in it too, and that's human menopausal gonadotropin, or Menopur is the brand name. But thinking back to our example about the menstrual cycle, and so this is just natural cycle with no drugs or anything. When we have our follicle developing and the estrogen goes up, the brain can sense that. So if someone were to do IVF without anything to prevent ovulation, the brain is pretty smart and it knows what's going on. So patients can surge and ovulate in the middle of their IVF cycle. So fortunately, we've figured this out, and through science and research over many years, but in some of the first IVF cycles, this happened. People took drugs and then ovulated before the egg retrieval. So now we know, and I mean, for decades, we've known that patients really need something to block that LH surge signal. So Lupron is one of the drugs that does that. And then there's another category of drugs, and there are 2 brand names in that other category, and those are ganirelix and Cetrotide. So all of those medicines kind of act the same way to prevent us from trying to ovulate.
Okay, and then they're also taking other an FSH as well, so that mimics their estrogen is rising, but we're trying to mimic, or we're trying to enhance that during these cycles.
Yeah, so this is always confusing to patients. So I think this is a great question, and thank you for asking this. Because a lot of times patients will say to me, well, why do I need all this medicine to do my IVF cycle? Can't you just go in there and retrieve my eggs? When we make FSH in a natural cycle, the goal of the body is to have one follicle with one egg develop. So we are selecting one egg or one follicle with an egg to grow and develop, and then the rest will eventually get reabsorbed. But when we do IVF, we want to kind of rescue those other follicles that would be reabsorbed anyway that month.
I see.
There's a higher dose of FSH in medication form than our brain would be making. So it's just sending a stronger signal to the ovary to rescue those other follicles with eggs so that they all grow and develop.
Okay. And a lot of women do frozen embryo transfers, and we're doing a lot more natural cycles there. So what's happening there? We're just going with a woman's natural cycle. And how often do we do that?
So natural cycles can be a really great option for people that have regular periods. So if a woman has a pretty predictable cycle and, for example, doesn't skip months or have really long cycles where it would be difficult to time things, it's really nice to just use someone's own natural hormones to support the embryo. So the way that process works is someone would go through the stimulation and the egg retrieval, and then fertilize the eggs, create embryos. And I should stop there and say some people, most of our cycles are still transfer in the same cycle as the retrieval, but I can give you a couple of different ways that could go. So sometimes patients are a transfer in the retrieval cycle, and a lot of those patients get pregnant, but if they don't and they have frozen embryos, they can do a natural cycle. Or sometimes patients are not having a transfer and they're freezing their embryos for one reason or another, and one reason is to do genetic testing on the embryos for chromosomal disorders, pre-implantation genetic testing. So to continue there, what happens is we freeze the embryos after they make it to the blastocyst stage, and then in the cycle that we're planning to do the transfer, the patient would just call on day 1 of her period. We typically have her come in around cycle day 10 for blood work and an ultrasound, and we want to check the lining of the uterus to make enough and looks appropriate for transfer. If not, we can repeat that ultrasound in a couple of days, and we do blood work and do it daily once we know the estrogen is high and that ovulation is coming. And the goal is to pick up the peak LH surge, and then transfer of the embryo would be 6 days after we pick up the peak LH surge. And most patients are using just vaginal progesterone supplementation in that type of cycle. So it's pretty easy. And then the pregnancy test is 9 days after the transfer.
Okay. And one last question about birth control pills, because a lot of times oral contraceptives are suggested. How does that play a role in, in a cycle, and what does that do with regards to the other medications they're taking?
Okay, so a great question. So we use birth control pills for a few different reasons. To give you one example, sometimes if someone has an ovarian cyst, they can take birth control pills for a short course, like 2 weeks, and then come in and do another ultrasound to see if the cyst has resolved, and then they could go into their cycle. Birth control pills can be nice for patients that don't have normal, for example, patients who don't ovulate on their own or have polycystic ovarian syndrome, to be able to get them into their cycle. So a patient could be on birth control pill and stop the pill and then schedule the IVF cycle. So that's one reason why sometimes birth control pills are recommended. The other reason that we use them sometimes is to help us boost someone's response. And this one's a little tricky, so I want to make sure I explain this well. And if anybody has any questions, please feel free to type them, because I want to make sure I don't confuse anybody. So at the beginning of the cycle, to just go back to our menstrual cycle example, we are hoping that at the baseline, at the beginning of the cycle, like on cycle day 2, for example, if a woman had hormone levels checked, everything would be low. So that includes, for some women who have a lower egg supply and a higher FSH, they may do better if they take some medication before the period starts to help keep the FSH low and synchronize the follicles so that every follicle is still small by the time we start. So to explain that a little bit better, if someone comes in to start their cycle and their FSH is already high, because naturally it's high, sometimes people can have a dominant follicle develop. So just one that gets ahead of the rest because it's already sensing the signal before we started our medication. And so you can sometimes get a better response if you keep that level low before you start your higher dose of FSH, so that you're not already starting the clock for that patient and kind of stimulating a follicle to grow ahead of the rest.
Okay. So I'm just going to look at some of the questions here. Meg said, glad you asked. That was my question. Prolonged luteal phase, utility in taking oral progesterone on a natural non-medicated cycle. I'm not sure. Does that make sense to you as far as what
so if someone has, if someone has a prolonged luteal phase, it's usually not a problem. It's just that they're producing a lot of progesterone.
Okay.
And that we don't think of as a bad thing. But if someone has a short luteal phase, you can use progesterone to prolong it. And if someone has that history, that's an option for them. So that would be something that you could talk to your doctor about if you've been tracking and you notice that your luteal phase is shorter. But people do this in non-medicated cycles too, in natural cycles. For example, I have patients that are trying on their own or have had miscarriages, and we notice that the luteal phase is a little bit short. So some of those patients will test with an ovulation predictor kit and start the progesterone like 3 days after they get their positive OPK, the ovulation predictor kit, and then continue until they can have a pregnancy test. And then if they're pregnant, they can continue the progesterone until we know the placenta is fully functional. And if they're not pregnant, then they can stop. They'll get their period. Sometimes, I just want to clarify that too, that sometimes the progesterone can delay the onset of the next period because it's supporting the lining. So if I have someone that is using supplemental progesterone, we do a pregnancy test before we stop their progesterone, just to make sure. And that's even if someone has like a home test that's negative. If they still haven't gotten their period, the safest option is just to do a blood pregnancy test and make sure we know for sure it's negative before someone stops their progesterone.
Okay. Does the use of progesterone change if the IVF patient is using a frozen embryo instead of a fresh one?
So I should go back and just say there are a couple of different types of frozen embryo transfer cycles. So in that natural cycle that I mentioned, since a patient is ovulating on her own, she's making some progesterone. So we feel really comfortable just supplementing with the vaginal progesterone. There is another type of cycle, and that is for people that don't ovulate, or for people that really like control over the timing of everything, or there are other reasons why we do that controlled cycle if someone needs a specific implantation window based on testing. But in those types of cycles, patients are on Lupron, which prevents ovulation. So they start that on cycle day 21, the day before their cycle starts, and then they would not be ovulating during that frozen transfer process. So for those patients, they do have the option of vaginal, but most of our cycles, we utilize intramuscular progesterone shots for those types of frozen cycles where someone is not ovulating and not making any progesterone on their own. And not to totally muddy the waters, but there's another type of frozen transfer cycle called a modified cryo-natural cycle, where patients can take a medication called letrozole to help boost their ovulation and then time the natural transfer. So basically, it really depends on the patient's history and their flexibility and scheduling too, because for the natural cycle, you'll get 6 days advance notice to know when your transfer is. And for a lot of people, that's okay, but not everybody. I have patients that absolutely cannot get out of work if they don't have, 2 weeks notice to tell their boss that they need coverage. So we can control the cycle for those patients. But there are ways, regardless of whether or not someone ovulates on their own, to get into these cycles and help us control things.
Here's a question. What do you do for women who aren't getting their cycle?
So for women, it depends on the types of cycle that we're talking about. So say it's an IUI cycle. We can use progesterone to bring on a period, and then medication to help and a lot of times we'll start with oral medication. Letrozole or Clomid are two examples, and they're pills that you take for 5 days during the cycle, usually starting like around the third day of the cycle, so third day of bleeding. So that's a way to get into an IUI cycle for someone that doesn't have periods. And the same holds true for IVF. You can use progesterone. Provera is one of the brand names, to bring on a period, and then once the period starts, have the patient come in and do IVF. Or the other example that we talked about before was the birth control pills. Sometimes patients will be on birth control pills, and then they can take their last pill and then schedule their cycle based on the day of their last pill.
Okay. And last question for IUI, is the purpose to make a female ovulate? We don't typically ovulate every month, but during IUI, will ovulation occur every treatment, especially if taking injections and medications? I hear of people who say they are on their second and third treatment, IUI treatment, a cycle. What is that?
Okay, so kind of it's two. I mean, we use the term IUI cycle as a term to just it's a blanket term. It means that you're having an intrauterine insemination, which is, let me grab a catheter, which is placing the sperm in the uterus on the day of ovulation with a little catheter that looks like this. So it's very skinny, and it's a way to get the sperm closer to the egg so that you're not losing millions of sperm in the vagina and cervix with intercourse. So that's the IUI, the intrauterine insemination process. But for some IUI cycles, patients are not taking any medication at all. For example, if they ovulate. And to give you an example again, I wanted to say that patients are coming here for different reasons. You know, we have people that have infertility, but we also have people that have never tried to get pregnant. They're either single women or they're in a same-sex relationship, and they may, for example, be using donor sperm. So a common never tried to get pregnant, they're just coming in to use donor sperm, that patient doesn't necessarily need to take any medications at all. So we can just have that patient use an ovulation predictor kit, and then on the day she's ovulating, we place the sperm in the uterus. But some patients are ovulating on their own, they've been trying for a year and they're not pregnant, and then when they come to us, they want to do things to increase their chances. So then they can start considering options like taking medication, like letrozole or Clomid, to boost their ovulation in their cycle with the IUI. Or for patients, obviously, that don't ovulate, the medication can be really helpful too. So if someone ovulates in their IUI cycle, you know, with or without medication, and then they have the insemination and then they're not pregnant, if everything went well, we would recommend trying that. But the cycle would be reviewed by the doctor, and we talk to the patient about you know, what she wants to do next. You know, for example, most patients don't have a lot of side effects on the medications, especially the letrozole. So I would typically make sure my patient felt okay on the medication and everything went well. And if she wasn't pregnant, then we could try again. So sometimes it does take more than one try to get pregnant with these procedures. And that's, I think, what we're speaking of here when people say, like, okay, I'm on my second IUI or my third IUI.
Okay. Okay. These are all great questions. Thank you, Dr. DeLuigi, for your time today. We really appreciate it. Some good questions that people have asked today too.
Thank you so much, Ami. So did we cover everything? I know it's a complicated process here. We actually have lectures on this topic that are, you know, 60 minutes long. It's a very complex hormonal system. The whole menstrual cycle, it's really amazing when you think about it, all the things that go on behind the scenes. So if anybody has any questions, just let us know. But it's been nice chatting with you, Ami, and I hope everybody has a great day.
That's great. And be sure to check out our website at uconfertility.com for additional information. And I think we'll add the chart that Dr. DeLuigi was talking about, the graphic, to the comments as well. And we'll see you next week for another Lunchtime Live.